That sounds like better than my beloved SGLT2 or GLP-1.
I know, it's like you'd put that in the water.
This is The Rounds Table. All right, welcome back, Rounds Table, Internetwork, MedPods listeners. A brand new format. This time we're going to be discussing guidelines, and in particular, the 2025 Acute Coronary Syndrome guidelines published in Circulation. John, are you prepared for us to unpack this beast?
I know, changing gears a little bit. Same idea though, right? Like guidelines are meant to be the best of evidence-based medicine. So I think it makes a lot of sense. And credit to cardiology. Like they always have some really nice, fairly clean guidelines too. So of all the ones to begin with, I think this is a good start.
Yeah, they have nice, clean guidelines because there are so many drug companies that want, drugs approved for cardiac stuff. They have so many trials. Okay, too early to editorialize. All right. So in these guidelines, there were thankfully 9 top take-home messages. And John and I are going to bat back and forth most of these messages. Not all. We're trying to make sure it's somewhat GIM focused. But first up, what was their first top take-home message? It was this. Dual antiplatelet therapy is recommended for patients with acute coronary syndrome. Ticagrelor or prasugrel is recommended in preference to clopidogrel in patients with ACS who are undergoing PCI. So I think this first point is much more of a refresher, but it is important that we think about what this is based on. So there have been some clinical trials that have compared these newer antiplatelets like ticagrelor and prasugrel to clopidogrel, and there seems to be a benefit with these newer agents. A quick reminder, remember that the dosing is a low-dose aspirin plus one of these newer agents, and the duration of treatment we will get to shortly. John, did this point surprise you?
No, I think we kind of are familiar with it at least.
Yeah, I would put this in the bucket of like things we're already doing, but certainly an important reminder. So I think that's all we'll say probably. The burning question is, well, for how long? And I think that is point 2 from the top 9 points. John, take it away.
So the next key point is around antiplatelet management and considerations around bleeding risk. So the 2025 guidelines give a few strategies for reducing bleeding risk in patients who have undergone PCI. First, and perhaps a more intuitive one, is that if the patient's at risk for a GI bleed, put them on a PPI. Now, there have been some concerns raised around drug-drug interactions with PPIs and Plavix or clopidogrel in particular because of concerns for maybe reduced platelet inhibition, but post-hoc analyses from several randomized control trials have shown that there's not an increased risk for ischemic events when PPIs are used with Plavix. And additionally, there does not appear to be a major drug-drug interaction between PPIs and the more novel ones like ticagrelor or prasugrel. The second kind of point related to this was that if the patient has tolerated dual antiplatelet therapy with ticagrelor, but there is concerns around bleeding risk, you can consider transitioning to ticagrelor monotherapy after about a month post-PCI. This is based on evidence to suggest that ticagrelor monotherapy reduces bleeding risk without a clear increase in major adverse cardiovascular events. So I guess one question is, well, why not clopidogrel or Plavix monotherapy? Well, the data has been mixed, and the concerns have been raised that clopidogrel monotherapy started 1 to 2 months after PCI may actually increase risk for MACE in patients with ACS. And then I guess the other question is, well, what about like good old aspirin monotherapy? And here, the concern is that the data would suggest there's higher thrombosis risk with aspirin monotherapy, but there is less bleeding. And then the final point is about, well, what about our patients who are already on long-term anticoagulation? For example, they've got AFib or a prior PE, and now they're being put on dual antiplatelet therapy, and there's GI bleeding concerns. In the patient with an indication for anticoagulation, aspirin discontinuation is recommended 1 to 4 weeks post-PCI, and they then recommend continuing with the P2Y12 inhibitor, and specifically in this case is actually Plavix. So wait a second, didn't we just say that ticagrelor is favored? Well, the recommendation here is for clopidogrel, and that's because the trials of the more potent P2Y12 inhibitors excluded patients with an indication for long-term anticoagulation. Additionally, in a really high-risk patient, the P2Y12 inhibitor could be discontinued earlier than 12 months if they're at a really high risk for bleeding.
Yeah, and that makes sense. So, I think the summary point is that for low-risk bleeding risk patients after ACS, often they're going to be on 12 months of that dual antiplatelet therapy. But for patients who are at high risk of bleeding, we've seen multiple trials that we've covered on the rounds table before, really suggesting that 12 months is probably not the right answer in the high bleeding risk patient, which makes sense. There's also some real nuance to some of the data behind the ticagrelor trials. I don't think we'll get into it today, but maybe for a future episode. It's making me wonder a little bit more on the safety of ticagrelor. And a quick reminder to the listeners, prasugrel, I think it's been discontinued by the drug manufacturer. So I know in Ontario you can't prescribe it. John, have you prescribed it anytime recently in Alberta?
I have never prescribed prasugrel.
There you go. I think it's fair to say, I think it's all of Canada. It's been discontinued and maybe the US as well. Cool. That's point number 2. What was point number 3? High intensity statin therapy is recommended for all patients with ACS and with the option to initiate ezetimibe. So the idea of high dose statins, this is unsurprising, but the guidelines had some nice tables which reminded me of things I have since forgotten. So when you say high intensity statin, really what you're referring to is atorvastatin, 40 to 80 milligrams once a day, or rosuvastatin, 20 to 40 milligrams once a day. John, my go-to is atorvastatin. Same with you?
Still love it.
Yeah, I think that has to do with like the hospital formulary. But anyway, they sure have got me to be set in my ways. And then lower intensity statins, just as a quick reminder, that's like the simvastatin 10, pravastatin 10, lovastatin 20. It was also a nice opportunity for me to refresh my memory on how much does LDL decrease by when you take a high dose statin. So approximately 50%. And that's how much it reduces LDL. How much does it reduce grandma or grandpa's risk of a subsequent ACS event? Approximately 15% relative risk reduction compared to moderate intensity statins. So I think, again, nice reminders for me here. This part I was not aware of. It said reassess LDL after 2 months of starting treatment to see how low the LDL has come down. Were you familiar with that, John?
Yeah, I know, because I think the cardiologists love being really aggressive with their LDL lowering, and so I'm not surprised to hear that.
Yeah, so this is a nice reminder for me, I guess. Maybe a cardiologist taught this to me and I forgot. And in the scenario where you've repeated it, and their LDL is above 70 milligrams per deciliter or 1.8 millimoles per liter, there's grade 1A evidence to add on another lipid lowering agent. So that might be something like ezetimibe. A quick reminder with ezetimibe, it lowers your LDL by maybe 20%. It does have adverse events, often, transaminitis. Some other agents are like PCSK9 inhibitors. I have never prescribed a PCSK9 inhibitor. John, how about you?
No, I have also never prescribed.
Yeah, okay, perfect. So we're on the same page and maybe our listeners are too. So in this setting, PCSK9 inhibitors, these are drugs like evolocumab, which I'm probably mispronouncing it, or alirocumab. Some cardiologists can tell me I said that wrong. And the data here is that these lead to a 15% relative risk reduction in MACE when it started 1 month post ACS and the LDL hasn't come down below the thresholds we mentioned. And then another snippet from this main point is that statin intolerance is frequent. That I have not remembered. That I was very much aware of because we see this in patients. And they reminded me the definition of statin intolerance is that if you've tried 2 different statins, including one at the lowest possible dose, that is when you say somebody is statin intolerant. So that was a nice pearl for me to carry with me going forward. I think that's about it for statins, John, unless you had questions on this point.
No, I don't think so.
Okay, back to you for the next point.
So the next key point is around the role for PCI in the setting of NSTEMI. So for the patient with an NSTEMI who somehow got admitted to GIM, call cardio back, because in particular, if they are at intermediate or high risk for ischemic events, the recommendation is to proceed with revascularization during the hospitalization. So what is intermediate and high risk? Well, this is usually defined with the GRACE 2 risk calculator or the TIMI risk score, and that's really to help identify those at increased risk for MACE. Now, in the patient with an NSTEMI, but thought to be at low risk for ischemic events, either routine invasive or selective invasive approach is recommended to reduce the risk. So what is routine approach? Routine invasive is where the decision is just made, go directly to PCI. In the selective invasive approach, this is where the next line of testing is with something non-invasive, be it a stress test or a coronary CT angiography. And if either of those are positive, then PCI should be done while admitted to hospital.
Yeah, that's a nice reminder for sure. It also just got me to pull up the TIMI risk score. That's on a list of things I forget and have to look up. So a reminder to the listeners, you get a point if you're 65 and older. You get a point for 3 or more CAD risk factors. You get a point for aspirin use in the past 7 days. You get a point for severe angina. You get some other points as well, but this is a really nice score available on MD Calc to then identify, is this person high risk? And it's certainly my go-to risk score. The GRACE I've heard of before. I've never used it. What do you guys use it in Calgary?
No, I also I try not to admit NSTEMIs, but if I'm having to think about risk stratification, then TIMI. GRACE is also though available under MD Calc. But I think it's like a version of the GRACE 2 score. But I won't bother speaking about it because I don't use it a lot.
Yeah, fair enough. I think less is more for my brain. When I'm up in Sault Ste. Marie, I'm the one admitting the STEMIs, the NSTEMIs. I wonder if it's similar at other community hospitals, but certainly it's like a nice refresher to go through these for my next trip up to the Soo. Okay, next up is back to me. This next item is a bit more for the cardiologists and maybe the cardiothoracic surgeons, but this next one is that a strategy of complete revascularization is recommended in patients with a STEMI. And when we say complete revascularization, so if they have multi-vessel disease, most often, the right answer is for the cardiologist to put a stent or 2 or 3 in the culprit lesion, and resist the temptation to touch the other lesions because it's either going to be a staged procedure or going to be a cabbage. And there's been quite a few trials actually comparing, PCI versus cabbage. I don't think I'll go deeper into the weeds than that. John, any burning questions with that one?
No, I think that one's, like you said, it's more for the cardiologist who's making the decision at the time of cath, but good to know what the recommendations are.
Yeah, and the other sort of sub point here is that especially for these patients, when they're hemodynamically unstable, get in and get out, stent the lesion and get out of there. But I'm not a cardiologist, so I will stop there. All right, John, what point's next?
So the next point places a lot of emphasis on secondary prevention following an admission for ACS. You kind of spoke about this a little bit already, but it's really about keeping an eye on what the lipid profile is. So a lipid panel should be done 4 to 8 weeks after the initiation of a statin or after any dose adjustment to decide on further dose optimization. As maybe a little bit of a segue, as internists, I think we see a lot of referrals for statin-related muscle injury. And if the statin is felt to be the culprit, because remember, there's other things that can cause, muscle symptoms, CK elevation, guidelines do recommend a de-challenge and re-challenge approach with considerations for maybe another class of statin, especially in the patient that really needs it, like someone who's had an acute coronary syndrome. Now, the other kind of big takeaway related to secondary prevention is the importance of cardiac rehab. In patients who have ACS, they should be referred to cardiac rehab before they're even discharged because cardiac rehab has been shown to reduce death, MI, admission to hospital, and improve functional status and quality of life in patients with ACS.
That sounds like better than my beloved SGLT2 or GLP-1, this cardiac rehab.
I know, it's like, put that in the water. It's a little hard to put cardiac rehab in the water, but...
I know, and I feel like it's like the hardest thing to get access to. It's almost like in the same bucket of pulmonary rehab, like works really well if you can get your patients into it.
Big time.
All right. So next up, is this the last one, John, or do you have another one?
No, I think you've got the last one.
All right, cool. This one is very much in the sweet spot of GIM hospitalist. So red cell transfusion to maintain a hemoglobin of 100 in Canadian units or 10 grams per deciliter in American units may be reasonable in patients with ACS and acute or chronic anemia who are not actively bleeding. So, this is based on 4 randomized trials, the largest of which was the MINT trial. And there's actually a really nice individual patient data meta-analysis published in New England Evidence within the past, 9 months or so. John, did you listen to the episode where I interviewed the first author of that IPD or no? Truth comes out.
I am guilty. I did not.
Oh, God, there you go. If you didn't, there's no way the listeners did. Okay, listeners, well, we'll put a link to it below. But that was a great conversation with Dr. Carson, who is a hospitalist in the U.S., and he has done a lot of work leading in this space, leading the MINT trial. So for listeners who somehow didn't hear that episode, a quick summary. So 4 randomized trials, overall, 4,300 patients included. And what they observed was that targeting a higher hemoglobin, okay, like get it closer to 90, 100 in general, patients appeared to do better compared to like, oh, let's wait till it's 70 or let's wait till it's 80, for example. So what they observed was potentially a lower risk of death, no increased risk in heart failure, because of course that's what we worry when we're giving people multiple units of blood. So they didn't see increased risk of heart failure. And then with the long-term data, they saw a reduction in all-cause mortality at 6 months, like a 1% absolute risk reduction, which is pretty meaningful, like absolute risk reduction of mortality by 6 months.
I'm not a good editorializer.
John has no editorializing comments on that one. So I will editorialize that. For me, I feel like we've been so used to teaching trainees, thou shalt not transfuse patients until their hemoglobin drops below 70. And I think for a lot of patients on GIM, that's the correct answer. I think it's the wrong answer if somebody's actively bleeding in front of you. And I also think it's the wrong answer for patients who are coming in with acute coronary syndrome. So certainly for me, when I'm up in the SU and I'm seeing a patient with a hemoglobin in their mid-80s coming in with an ACS, I am transfusing them, getting them closer to 100. But it sounds like all those patients aren't cared for by GIM in your 4 walls, eh?
No, we do still get some cardiology admissions to our wards, but I think it's an important point from these clinical trials. Like, yeah, we'd always kind of considered, hey, I guess maybe transfusion threshold above 80 in the patient with active anginal symptoms. But yeah, like, they've got ACS, get their hemoglobin higher.
Yeah. And with Dr. Carson, like he acknowledges it's nuanced, right? If the patient's in flash pulmonary edema and they have ACS and their hemoglobin's 80, you're going to give them another unit? No. But for the patient where they're relatively stable, the benefits probably outweigh the risks. Well, those were the main top take-home points from the 2025 ACS guidelines published in Circulation. I asked ChatGPT, I said, hey, ChatGPT, we're going to record this podcast. What are the top 3 most relevant updates from these guidelines? John, do you want to guess what ChatGPT guessed were the most important points?
Okay. Maybe we'll just say, I don't know, transfusion, one of them. Something to do with antiplatelets. But I mean, I don't know if ChatGPT would have the nuance of like, what aspect of it, and then I don't know, and STEMI PCI, just because I cover that one.
Yeah, you'd think so for sure. Okay, here's what ChatGPT's points. Number 1, this refined dual antiplatelet therapy recommendation. So John, gold star for that. It summarized it as low bleeding risk, aim for 12 months, high bleeding risk, consider shorter duration, and tailor to minimize bleeding complications. The next point that ChatGPT thought was so useful for the hospitalist was enhanced cardiogenic shock management related to mechanical support devices like microaxial pumps like Impella. Swing and a miss there. We skipped that point because that really did not feel relevant. And then the third point it said was strengthen secondary prevention strategies, aggressive control of LDL. And then the fourth point was actually watch out, AI's coming for your jobs. That was the fourth point it had for cardiologists and hospitalists.
AI's getting aggressive, eh?
Yeah, exactly. It is unhinged Grok style. All right, listeners, I think that's all we have for these guidelines. Let us know if you'd like this new format. John, any good stuff to discuss before we wrap up?
My good stuff is a bit out of left field. So I don't know if you eat a lot of eggs, but I'm not always a good egg cracker. I get shells everywhere. I got to find what the original source was, because this was not my idea, full disclosure. But did you know that if you drop your egg from, let's say, like 3 inches, 4 inches of height into a bowl, the likelihood of it cracking and shattering the egg is very, very low. I've had about a 95% success rate.
Yes, I knew that only because the YouTube algorithm thought this would be a useful video for me. There's this awesome channel called Fireship that I follow on YouTube, very much AI, computer science, programming heavy. This is not my good stuff though, but he somehow incorporated it. So that's the only reason why I knew about it. On my end, a great DJ called Jerro. I don't know if you listen to any of his stuff. He just put out this new coffee shop set and just great 60 minutes to listen to and go for a run, get work done, whatever.
Oh, cool. How do you spell it?
Jerro.
All right. I'll check him out.
Just type in Jerro Coffee on YouTube and it is some good stuff. All right, that's it. Those are some guidelines. We'd love to hear people's feedback and let us know if we should do this again or back to the usual stuff. All right, John, have a nice weekend. Take care.
Talk to you later, Mike. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.